aneurysm. So ventricular aneurysm means a bulging or outspouching of the weakened wall of the heart's ventricle. Ventricular aneurysms predispose patients to increased risk of ventricular arrhythmias and sudden cardiac death, congestive heart failure, and also the presence of mural thrombus and subsequent embolization. There are lots of causes of left ventricular aneurysm. Here we are talking mainly about left ventricular aneurysms because right ventricular aneurysms actually are very rare. So we will just focus on left ventricular aneurysms. So as I said, left ventricular aneurysms, they can be caused by acute myocardial infarction, which is by far the most common cause, because myocardial infarction causes myocardial wall necrosis, and this necrotic wall becomes so weak that it dilates, and after it dilates, it may form an aneurysm. And STEMI is known as the most common cause of left ventricular aneurysm, while, as I said, right ventricular aneurysm is rare because also the right ventricle has lower pressure. Other causes of left ventricular aneurysm include cardiomyopathy, cardiac infection, and congenital abnormalities. In clinical practice, we have to differentiate between true aneurysm and pseudoaneurysm. So in general, the true aneurysm bulge is contained by all the three layers of the original vessel wall. And in pseudoaneurysm or the false aneurysm, it's not a true dilation of the vessels, but rather a contained rupture, where the blood has leaked through a hole in the vessel wall and is contained only by the outer adventitial layer or by a surrounding scar tissue and clotted blood. If we are talking about the heart, the pseudoaneurysm is surrounded only by the pericardium. So this structure of only surrounded by the pericardium gives us a shape with a very small neck, as seen here in this picture of echocardiography on the left. It's pseudoaneurysm or false aneurysm. Here we can see other pictures showing the difference between them. So on the left side, we have a false aneurysm with a narrow neck, as you can see, while on the right side we can see a true aneurysm of the septal wall of the left ventricle. Here is another example. Here we can see also a true aneurysm of the lateral wall of the left ventricle. But here the difference is you can see a thrombus, which is located below the posterior mitral leaflets. Let's talk about ECG. So ECG features of left ventricular aneurysm will include ST elevation, which is seen more than 2 weeks following an acute MI, because generally after an acute MI we will see ST elevations that would resolve mainly after these 2 weeks. And generally, if we see the presence of ST elevation, which is after this 2 weeks period, we can suspect the presence of left ventricular aneurysm. This ST elevation is most commonly seen in precordial leads, and it may exhibit either a concave or convex morphology, but it's usually associated with a well-formed Q wave or Q wave complex. The T waves have a relatively small amplitude in comparison to the QRS complex, unless the shape of the hyperacute T waves which are seen in acute STEMI. And this pattern of persistent anterior ST elevation more than 2 weeks after STEMI, plus pathological Q waves, it has a sensitivity of 38% and specificity of 84% for diagnosis of ventricular aneurysm. So mainly, this degree of ST elevation which remains in 60% of patients with anterior STEMI and about 5% of patients with inferior STEMI, and this mechanism is thought to be related to incomplete reperfusion and transmural scar formation following an acute STEMI. And the ECG pattern is associated with paradoxical movements of the ventricular wall on echocardiography, which is the ventricular aneurysm. And post-aneurysmectomy ST elevations, they are seen in 61% of cases, but they may regress in about 26% of cases. So, how to differentiate between an acute STEMI and a ventricular aneurysm or left ventricular aneurysm? So there are some factors which are favoring left ventricular aneurysm and there are factors favoring an acute STEMI. When it comes to left ventricular aneurysm, if we have of course a previous ECG, it will be perfect because ECG will be identical to previous ECGs. If not, we can check for the patient. For example, if the patient is looking sick, pale, sweaty, hemodynamic instability is present, presence of ischemic chest pain, of course we will have a high clinical suspicion of STEMI. We can look for the absence of a dynamic ST wave changes or the presence of a dynamic and progressive ECG changes. So if there is a progressive ECG changes, of course this means that this favors an acute STEMI because usually in acute STEMI the degree of ST elevation will increase on serial ECGs, and also you will see on ECG of an acute STEMI a reciprocal ST depression, while for left ventricular aneurysm we will see an absence of dynamic ST segment changes, and there will be an absence of reciprocal ST depression with a well-formed Q wave. There is also something called the ratio of C wave on QRS, which has been validated as a mean of differentiation between left ventricular aneurysm and acute STEMI. So mainly we calculate the C wave and then we divide it by the QRS ratio. If it's less than 0.36 in all the precordial leads, it favors left ventricular aneurysm. While if it's more than 0.36 in all the precordial here in any precordial lead, it favors anterior STEMI. So for the first one, for left ventricular aneurysm, in all of the precordial leads, while for the anterior STEMI, in any of the precordial leads, it favors an anterior STEMI. Here we have our first example of ECG. So we can see the presence of ST elevation, but this ST elevation, we can see that we don't have this acute T waves. So we have just a small ST elevations which is present in lead V1, in V2, and in V3. It's mainly seen in V2. We can see also T waves are negative in V1, in V2, in V3, V4, V5. In V6 it's hardly seen, but it's also seen as well in AVL. It's negative in AVL as well. So this patient, mainly it has an anterior wall aneurysm. Why? Because we have a well-formed Q waves. If you can see in V1, V2, V3, this ST elevation is accompanied by a well-formed Q wave. And we have also on the inferior leads, lead 2, lead 3, and lead AVF, it should be reciprocal ST depressions if it's an acute STEMI, but it's not present. And the patient was asymptomatic, and repeated ECG recordings were the same. And taken from the history of the patient, he had previous anterior STEMI. So, this patient has a well-formed Q waves. He has ST elevation present in anterior leads V1, V2, and V3, negative T waves in V1 till V5, and in AVL without reciprocal ST depressions. And still the patient is asymptomatic. So this patient has left ventricular aneurysm, mainly of the anterior wall. Here let's have a look at another example. So here we can see ST elevation in lead 2, in lead 3, and a lead AVF. But we can see as well the presence of a pathological Q wave, which is seen in lead AVF and which is seen mainly in lead 3. And the patient doesn't have SC depressions which are reciprocal from V1 till V3, which are reciprocal to the inferior leads of SC elevation in lead 2, 3, and AVF. Usually in acute inferior wall STEMI, we will have reciprocal SC depressions from V1 till V3. Here it's not present. And mainly the patients here will have a left ventricular aneurysm, but of the inferior wall, because we have here ST elevations in lead 2, 3, and the AVF. Having a left ventricular aneurysm in the inferior wall is actually a rare type of aneurysm. So, in conclusion, the patient has Q waves, which is formed in lead 3, in lead AVF. And we have ST elevations, not an acute one, in lead 2, in lead 3, and in lead AVF, without reciprocal ST depressions in lead V1 till V3. The third example, here we have ST elevations, as you can see in lead V2, V3, V4, and V5. And we have the presence of a pathological Q waves from lead V1, V2, V3, V4, and V5 actually. And we have the presence of right bundle branch block. G waves are negative in V1 and in V2, in V3, and in V4. If we have a look at, this is like, it looks like an anterior STEMI, right? So if we have a look at reciprocal ST depressions, we have in lead 2, G waves are positive. Lead 3, it's actually a bit negative. And we have lead AVF, it's positive. So, taking into account that we have a very well-formed Q waves in V1 till V4, which are pathological Q waves, and ST elevation in V2 till V5, without a very big ST depressions present in reciprocal leads, and taking into consideration that the patient here was asymptomatic with repeated ECG recordings showing the same ECG, we consider that the patient has a left ventricular wall aneurysm and mainly it will be anterior. Now coming to the management of left ventricular aneurysm, it depends on the symptoms of the patients and it depends on the size. It can include either medical or surgical options. The medical management involves controlling risk factors, for example, hypertension, using medications like ACE inhibitors, and potentially we can use anticoagulation. Surgical treatment is considered for larger or symptomatic aneurysm. It involves reconstructive surgery with patches to repair the damaged area and reshape the heart. It can involve procedures like the door procedure, which is used to reshape and reduce the size of the left ventricle by excising the aneurysm and removing any clots and using a synthetic or biological patch to close the defects and restore the normal cardiac geometry and improve the heart function. Other surgical procedures can be like Cooley and Stoney procedures, and surgery is the preferred treatment for pseudoaneurysm due to very high risk of rupture and bleeding. And that's all for today. I hope it was useful. Thank you for watching.